I'll call the meeting. Thank you, everyone, and welcome. Essentially, I'll go right to the agenda with our traditional land acknowledgement statement, which reads as follows. Leeds, Grenville, and Lanark are located on the traditional territories of the Anishinaabeg, Huron-Wendat, Haudenosaunee, and Oneida, dating back countless generations. We would like to show our respect to Indigenous peoples for their contribution and recognize their role in treaty making in what is now Ontario. Hundreds of years after the first treaties were signed, they are still relevant today. Our next agenda item is the approval of the agenda. I have a motion and I've indicated some names beside it. If you have a concern, let me know. It moved by Bill Dobson, seconded by Tony Circo. It reads that the agenda of February 24th, 2022 regular meeting be approved as circulated. Is there any additions that anybody wants to make or comment? If not, I'll call the question. All in favor? And the motion is approved. Thank you. With our agenda approved, can anybody advise me if they have a declaration of interest and if they could provide the details thereof, if there are any? I'm seeing none, so we'll move on to item 5, which is our consent agenda. And for this, I have moved by, Peter McKenna. I'm going to have to switch here quickly. Seconded by Bill Dobson. The motion reads that the following items on the consent agenda be approved as circulated. They are 5.1 minutes from the Board of Health regular meeting held on January 27, 2022. 5.2 general correspondence. 5.3 MOH CEO duty of care report. 5.4 governance and quality assurance committee duty of care report. 5.5 2022 Board of Health work plan. 5.6 the Q4 report, and 5.7 borrowing authority. Does any member of the committee wish any of these items to be dealt separately? Peter, go ahead.
Thank you, Mr. Chair. Just, I wonder, under the general correspondence, there's an interesting item regarding regional versus local governance of public health units. Not for discussion today, but if the board was interested, I wonder if we could put it on the next board meeting for discussion, just to consider that. So that was my question.
I think we can handle this by consensus. I think it's, anybody want to comment on the suggestion that we do this?
I was going to make a comment as well on that item, noting that 2 health units had done some significant advocacy work in that declaring or writing to the ministry, and I was thinking that we might want to explore a little bit more what the process is for that kind of a letter to go out of a health unit. Is it a board letter? Is it a staff letter? And what is the process? And I would like to suggest that go to the governance committee for discussion and bring it back to a further discussion, part of the generative discussion in that process, perhaps.
All right, thank you for that. So that is in agreement with Peter and also indicates that the venue should be the governance committee. Do I have consensus on that? Does anybody object? I'll just go this other way. All right, it looks like everybody is consents that we will do this. And Peter, you're agreeable that it would be at the governance board? All right, thank you for that. So I'll return then to the motion because that's not actually wishing to be separated. And so I'll call the question. All in favor of that motion? Okay, thank you. So the motion is carried. We're on to presentations, and for that we have the presentations of 2022 COVID-19 surveillance. And I have on it, I got initials here and I'm forgetting. Paula, help me.
Yeah, so when we presented all the detailed information about what we had done in 2021, there was some interest in learning more about wastewater surveillance and about the surveillance program overall, which has really had to change dramatically. So, and it's been a while since John Cunningham came and interested you and enticed you with the work he's been doing. So I thought this is a good time to do it. So John is going to give you like a fantastic overview of wastewater surveillance, and Hanan Atwi, who is a public health inspector who we've recruited in to help John. She has a master's in public health. Will give you an overview of how we're doing our surveillance now without having all the detailed lab results we have for everyone in the community. So I'll turn it over to Hanan first of all.
All right, thank you. And I'll just ask the speakers, do you wish to go through your presentation first and then questions, or questions as you go? And
I would say after the presentation would be best.
all right, that's fine then.
I agree with that. Thanks.
Great, then why don't you go ahead, Hannah?
Thank you very much. Good afternoon, everyone. My name is Hanan Atwi. I'm the Health Information Analyst at the Health Unit. And today I'll be presenting on the Leeds, Grenville, and Lanark District Health Unit's updated COVID-19 surveillance dashboard that we have developed. I'll be going over the surveillance indicators in terms of meaning and trends, as well as the changes that were made. Okay, thank you, Paul. So in response to the rapidly spreading and highly transmissible Omicron variant, the Ontario government made significant changes to the eligibility for publicly funded PCR testing effective December 31st. Publicly funded PCR testing was limited to symptomatic high-risk individuals and individuals who work in high-risk exposure settings to ensure that the most vulnerable Ontarians have access to COVID-19 testing. These changes meant that the positive cases confirmed by PCR testing will significantly underestimate the true number of individuals infected with COVID-19 in the community. To address this, many local public health agencies changed how COVID-19 cases are reported in their regions. On Friday, January 14th, the Health Unit posted an updated COVID-19 surveillance dashboard in response to these changes. So what changes were made? We are now using a hybrid approach to our COVID surveillance reporting, using case information, and have added Sentinel for COVID. The new LGL dashboard includes counts of daily new lab confirmed COVID-19 cases, which are limited to the population eligible for PCR testing, as well as trends for COVID-19 cases by date, trends for COVID-19 hospitalizations by date, as well as COVID outbreaks in high-risk settings. We also added a few Sentinel indicators, including respiratory-related emergency department visits and COVID viral material detection in municipal wastewater. So what are Sentinel indicators, you ask? Sentinel indicators are not directly linked to COVID, but provide an idea of how COVID may be circulating in our community by tracking community trends. We also discontinued various sections in our previous report, including variants of concerns, as we know that Omicron is the dominant variant and only a small number of PCR tests will be screened for Omicron. We also stopped reporting on cases by age, source of acquisition, and geography, since high-risk cases only represent a small segment of the population and are not community-based. And lastly, we have stopped reporting cases per 100,000 population, as case rates no longer reflect the true rate of COVID-19 in the whole population. Next slide. So I'll begin by going through the various sections of the dashboard to help familiarize you with its content. On the first page of the dashboard, you can see the number of high-risk cases added since the last report and a hospitalization summary. Hospitalizations is a good indicator of the severity of COVID-19 in our community and can help track how well LGL is faring with the virus. Throughout January, the number of hospitalizations, ICU and ventilation bed occupancy in LGL were the highest counts we have seen since the beginning of COVID. In February, hospitalizations began declining and have continued to show a downward trend. So next slide. So on the second tab of the dashboard, you can see lab confirmed cases and hospitalizations. Notice the dotted line on both graphics. This represents the start date of the new provincial testing direction. And you can see in the top graphic how our daily case counts dropped off significantly after December 31st. This is because the indicator of daily new lab confirmed COVID-19 cases only shows case numbers associated with high-risk settings and high-risk individuals and excludes everyone else in the community. The adjacent table shows the number of new cases by day, which again is limited to the population eligible for testing. The reason we included this is because the public has been following case counts from the very beginning of the pandemic and have been quite adamant on reporting of case counts. So this table gives them a little bit of that information, even though the counts only represent a small segment of the population. The next graphic is an important one and shows new lab confirmed COVID-19 hospitalizations by date. You can see leading up to December 31st, how our hospitalizations began climbing incredibly fast. What this graphic does is give an indicator of the severity of illness in our area by date. The yellow line that you see represents accumulative hospitalizations counts. By the slope of the line, it indicates as to the direction of hospitalization trend. And as you can see, it's beginning to somewhat stabilize and flatten. We just don't want to see it as an exponential trend, which shows that things are getting dangerous in our healthcare system. So that would mean that the yellow line would be moving upwards. Next slide. The next page of the dashboard shows lab confirmed outbreaks, which has now replaced our weekly outbreak report. The first graphic shows weekly trends for new lab confirmed COVID outbreaks. As you can see, prior to December 31st, we saw outbreaks in various locations, such as childcare facilities, workplaces, and schools. After the new COVID testing eligibility, outbreaks were mostly in congregate care facilities, such as long-term care homes and retirement homes. And the table below highlights open COVID-19 outbreaks by location type, number of cases associated with those outbreaks, as well as the average number of active cases per outbreak. Next slide. The next half of the dashboard focuses on Sentinel Surveillance, which has been newly added to the report. This page shows hospital emergency department visits, which pulls data on all residents of LGL who report to a hospital with respiratory symptoms or influenza-like illnesses. Respiratory-related emergency department visits may not be COVID-specific, but may be COVID-related. However, by looking at the volume of people going into the emergency department with respiratory symptoms, this may give us an idea of something going on in our community. The data related to hospital emergency department visits captures all residents of LGL. For example, if a person resides in Almont, but reports to a hospital in Ottawa, we will still collect this data as the person is a resident of our health unit jurisdiction. In the graphic, the blue bars show daily case counts and the orange line shows the moving average of those case counts just to smooth out any variability. As you can see, after December 31st, there was a decline in the number of ED visits, and this may be associated with a couple of things. People have been encouraged not to visit the hospitals to preserve capacity, which may have impacted the numbers. As well, at the beginning of COVID back in February, March of 2020, our emergency department visits were very high, and that's typical during influenza season. As soon as COVID hit, they dropped right off. So the public seems to be quite sensitive to being told to stay away from the emergency department. Another possible factor may be related to restrictions to COVID testing eligibility, as people may be less likely to visit the ER with respiratory symptoms if they know they won't be tested for COVID. Next slide. The final indicator is our wastewater viral detection indicator, which monitors COVID-19 viral particles in municipal wastewater. This Sentinel indicator provides an early indication of the presence of COVID-19 by gauging the level of COVID-19 presence in our community and tracking community trends. This is especially important when access to clinical testing for COVID-19 is restricted, as currently is the case with testing eligibility. The orange line shows the viral signal that the lab reports back to us, and the viral signal detects COVID cases in the area. So I won't get into this too much because John will be covering this in his presentation. So I'll let him kind of cover that for us. Next. So that's it for me. If anybody has any questions, this is the time to ask.
Yes, does anybody have any questions for Hannah? Go ahead, Peter.
Thank you very much, Hannah, and very nice to meet you via Zoom. I was thinking about the future and the reports that are going to be written by healthcare historians, academics, etc., to really understand the pandemic, let's say in 5 and 10 years from now, reflecting back. How will they be able to get a better sense of the actual count and the impact of that if we aren't, and maybe this is a question for you, but how will they understand the true impact when we aren't testing to the way we were? Will we just estimate, and will that really help us in learning as much as we can from this pandemic?
That's a great question, Peter. And you make a great point. If you aren't collecting data, you really won't know what's happening. So with the decision that was made by the provincial government, it sort of shifted, how to look at, ending this pandemic. Do we really know what's going on? However, the indicators that we chose to focus on, they really do help kind of focus our attention on where it needs to be. In the hospital settings, that's the whole reason why we were, very careful of what was going on in the healthcare system. So the indicators that we have presently, they really do help kind of gauge where we're moving with the pandemic. But in terms of actual case counts, we'll never really know that information. They'll have to probably hypothesize or estimate.
Thank you, Hannah. Dr. Stewart, did you have something to add?
Yeah. If we had a ton of capacity to do at the assessment centers to test everyone who had COVID, and we had incredible lab capacity, I think we still would be testing people. The trouble is we don't have that, and that wasn't a good use of our resources, really, because we now know that COVID is easily spread, and so it was really a decision to focus our resources in places other than the assessment center and the lab, to keep those resources as they are right now, and not expand them. And honest to goodness, there was a point where we were getting lab tests back 5 or 6 days after the testing had been done, which was not very good, because then we didn't know that someone had COVID until they were well into it. So I think it's just a reality of what happened with Omicron, that it just spread so quickly and there were so many people that it overloaded the system. I think the wastewater surveillance that John's going to tell you about is actually become a marker that the province is using, and to help us understand what is going on at the population level. So there's ideally what we'd like to have, and then practically what we have with the resources we have right now.
If I may, I thank you for that. It was in no way a criticism of the change in approach and testing. I agreed with that. I just worry that when we have time to look back and reflect, and maybe it will be the wastewater that will be a better, I just wonder where they're going to get the data so that we can learn from it, but that's fine. Thank you.
Yeah,
Bill
I agree.
Bill Dobson, you had your hand up.
Thanks, Mr. Chair. Yes, just a quick question. Are we getting the results from all of the wastewater treatment centers now? Like, I know at the beginning, I thought maybe, Paula, you were saying that we hadn't been looking at the one in Smith Falls and Carlton Place. But I'm just wondering, are we using all of the treatment centers now? And when you compare them, are they all similar and fairly consistent?
So hold that question, Bill, until John does his presentation. That's a great intro for him.
Exactly. Thank you. Okay, so we're still on 6.1. And John Cunningham, please go ahead with your presentation.
I had my hand up as well, Doug.
Oh, I apologize.
Okay.
Go ahead, Cheryl.
It's an observation and a suggestion more than a question, and that is that we've seen such an uptake in people going to the website of the public health and using that dashboard. And I'm hoping that we can sustain that over time, and that the surveillance role of public health is reinforced by keeping some kind of look at the community live on that website. It won't be COVID, but it could be flu, or it could be outbreaks of measles or whatever, as a way of keeping the community aware that science is driving policy decisions. And I think that's a really important connection to keep in the community. So I appreciate that we have somebody who is able, people on our staff who are able to do that kind of analysis and drive, help us drive policy decisions.
Yeah, so that is music to John and Hanan's ears, because they are actually looking at what can we be doing beyond what we are now. Because you're absolutely right. Let's take advantage of the interest. Yeah, totally agree.
Thank you for that, Cheryl, and I apologize for missing your hand on the screen. So John, can you go ahead then with your part of the presentation?
Sure, Mr. Chair, thank you. Before I get started, I just want to thank you for inviting Hanan and myself to present today. I always love chatting with the board. It's very insightful for us. Before I get into it, just following up on Peter's question, we have an idea of the reproduction number of COVID and the various strains of COVID. The reproduction number is just the average number of people infected by a single case. So I think moving forward, there's going to be a lot of modeling based on that, based on our populations and how the disease varied between populations, et cetera. So I think they'll have a pretty good handle on having an understanding as to who was infected and who wasn't with the disease moving forward. I mean, it's going to be a bit of a statistical landmine to, minefield to go through, but I think they'll do a pretty good job. They've done this before. So getting into it, hopefully I'll answer some more of your questions as we go. So I'm going to start with what is wastewater surveillance, just to give you a more in-depth description of what we're doing here. It's really a partnership between the Ontario government, and that's the Ministry of the Environment, Conservation and Parks has led this up, academic and research institutions, municipalities, and public health units across Ontario to detect SARS-CoV-2 or COVID, viral RNA particles in wastewater samples taken from communities across Ontario. Currently, there's over 100 communities taking part across 34 health units. Now, the wastewater surveillance involves the testing of municipal sewage for the presence of COVID-19 RNA particles. The key advantage of this system is that a single test represents an independent signal from the entire population of that sewer shed. When I say sewer shed, you likely know it's the wastewater infrastructure of a municipality, the physical pipes and the treatment plant. Wastewater surveillance can detect viral shedding in symptomatic and asymptomatic cases, and this is really important. A person, as you know, may be COVID positive, but walking around without any symptoms. And this is really important in terms of them infecting other people. So when we can detect a signal from a municipality in advance of actually seeing an outbreak in that municipality or increased case counts in that municipality, it really gives us an early warning or a heads up as to something potentially going on. And I'll expand on this a little bit more heading forward. It's when combined with other forms of testing, as Paula discussed and Hanan discussed, wastewater surveillance is really an adjunct to all of these other types of testing and types of surveillance that we do, in addition to other epidemiological data. So it really has a potential of predicting COVID-19 disease trends, but it's just a part of that. It's not a standalone yet anyway. It's rapidly evolving in terms of how it's being used, and it's being refined. There's over 1,000 sites worldwide, 1,000 municipalities reporting in 50 plus countries using this very system. And there's many theorized applications of it after COVID-19, and we discussed this already, but there are many infectious diseases of public health significance that we could monitor using this system, including opioid use, et cetera, within our population. So once again, giving us that early warning. Next slide, please. So how does it work? Well, most people shed viral COVID-19 RNA in their urine and their stool. Peak viral shedding can occur just before COVID-19 symptom onset. So it's having a system in place that monitors this can be very valuable to us from a public health perspective. So how does it work? Well, sewage is collected in a series of pipes, and they are channeled to the primary clarifier in our wastewater treatment plants. And that's where the sewage samples are collected. It's collected from the raw sewage as it comes into the plant. This sewage is collected as a sample. It's sent off to a lab. Our lab here is the Carleton University up in Ottawa. There it's centrifuged into a solid pellet, and the nucleic acid is extracted from this. Then it's quantified, and that's using PCR, polymerase chain reaction technology, to amplify the viral signal. And you've probably heard of PCR quite a bit now, and you'd never heard of it before COVID-19. Now everybody talks about it all the time. After that signal amplification is done of the nucleic acid, then it's normalized. And what do I mean by that? In order to take out a lot of the variability of the viral signal that can occur, it is normalized with a virus that normally occurs in human waste, and this is called the pepper mild mottle virus. Apparently, it's very common in the human digestive tract. And by normalizing against this, we can take away some of the variability caused by seasonality, caused by changes in your population size, caused by changes inputs into the sewage systems. For instance, if you have a melting event during the winter where a lot of water gets into the sewer systems, or a lot of salt runoff gets into the sewer systems, it can really affect the viral signal that's detected. So this normalization really smooths that out. Next, please. So there's a long workflow involved in this whole process, and I'll go quickly through it. First, it's our municipal partners. They're the ones that actually collect the sewage sample at their wastewater treatment plants. The Wastewater Surveillance Initiative really works hard with municipalities to make this as less impact as possible on their daily work, because they're busy people. So when a technician collects a sample, and it's usually done every 2 to 3 days in a municipality, the Wastewater Surveillance Initiative sends them the sampling equipment, they send them the refrigeration equipment, and they pay for the couriers to send the samples up to Ottawa to be tested. So they try and cover as much as the cost and the infrastructure around collecting the sewage samples as possible, to make it as easy on the municipalities as possible. Once the sample is sent to Ottawa for analysis, it's concentrated, the virus is extracted and detected, the quality assessment and quality control is done, and then they report the data. They report the data not to the public, but they report it through a password-protected web portal that the municipalities can access and that public health can access. And we take that data and then we report to the public in a very boiled down, simplified version, because the reports that are produced by the WWSI people are very technical and they're very statistical. Next slide, please. So the web portal we look at the web portal for daily access, and they also produce very technical weekly analytic reports as well. Currently, we have reporting from Brockville, Kentville, and Smiths Falls just came online, which is great. This is a screenshot here as an example of the web portal that you can access, showing viral signals, showing case counts, which, as Hanan pointed out, aren't exactly useful anymore as indicators. However, before the testing regime changed in Ontario, the case counts we were seeing from municipalities correlated really well with the viral signals we were seeing, showing that this technology is really useful as a reporting tool. Next slide, please. So there's a few things on this slide I want to point out, then we'll get into the individual sites. First of all, it's integral to our ongoing Sentinel surveillance and reporting, as Hanan has pointed out. As well with this slide, you can see that This is actual data from the Brockville site. So the orange line on the top is the actual viral signal, the moving average of that's reported, and that's up to yesterday, I believe. The horizontal dotted, the vertical dotted red line here indicates December 31st when the testing regime in Ontario changed. If you look down at the lower part of the graphic, the gray bars, those are actual case counts for Brockville, daily case counts that we were seeing lab confirmed for COVID, and you can see that we're increasing, almost exponentially day to day up to December 31st, and then they fell right off. And that just shows how the change in testing regime really affected our ability to see from a population level how many cases we're getting in terms of COVID in our regions. So big change there. But if you notice the viral signal, it's increased and stayed increased, and then it slowly started to decrease about 2 weeks into January. And we've seen this trend right across the province in terms of various reporting, in terms of hospitalizations and deaths and case counts and outbreaks. Things correlate pretty well with this little signal we're seeing here. Now, the signal is kind of messy, as you can see. It varies quite a bit day to day. That's just the nature of the beast with this kind of thing. So many inputs into the sewer system can affect, it's very sensitive to input. So, even though the normalization of the signal is done and the standardization to take out a lot of the statistical noise, it still occurs. But if you put an overall trend line on these things, it does a good job at showing what's going on in terms of COVID in our communities. Now, you'll notice here, just to point out, around mid to late December, the holiday season period, the signal in Brockville fell right down to zero, then increased again in late December, early January. That's probably a result of just lack of testing during the holiday period. People were on vacation, etc. So tests weren't being sent to the lab, and that's likely why that signal dropped down to zero there for a little while. All right, next slide. So this is Brockville, and as I pointed out, if you look at general trends in these signals, they do a fairly good job at showing increased COVID activity in our areas based on wastewater. The upwards trend from late November to mid-January, that's what we saw right across the province in terms of cases increasing in current terms of hospitalizations, etc. So this really correlates well with that. And since mid-January to current, things have been calming down. The signal overall has been falling. Late last couple of weeks here in Brockville, we saw a spike in the signal, but it's fallen down to normal values again. Next, please. This is the Kempville site, and similar pattern, but different pattern. Each site is different. So we're going to get a different signal from each site, and that's dependent on the populations, depending on the wastewater infrastructure of the municipalities, and it's dependent on the number of people that are positive for COVID. And it's difficult because everybody expresses COVID differently biologically, right? So some people will shed a lot of virus, some people won't. So we're always going to get a lot of variability with these signals, but the pattern is almost the same, really, to Brockville in terms of onset, and around mid-January, the signal turning around and starting to decrease. And the final slide shows the Smiths Falls site, which, it's just been a few weeks since they've been online, so we don't really have enough trend data to really make any determinations based on this. All right, last slide, I believe. So what does this all mean? I've said a lot. Wastewater surveillance is not a means to estimate precise disease prevalence in a population. However, with other indicators, as Nan has pointed out, and especially with clinical testing, it is good for assessing trends in infection rates. It does not identify or specify sources of COVID-19 the way we're using it, or the likelihood of ongoing transmission the way we're using it. However, it has been used in certain applications, especially down in the States, on university campuses, where they're actually doing monitoring at the dormitory level. So they know exactly where on this campus the outbreak started based on individual buildings on the campus. So it can be used a variety of scales. It's a complement to other data sources. It's not a standalone surveillance tool, and that's normal for Sentinel surveillance. They're not meant to be used alone. They're meant to be used, as Paula has said, a triangulation of evidence. And that's, I'll go to the last point and then go back one. You know, it's not a fine-tuned methodology for determining COVID-19 in our region, but it does provide a piece of evidence when cross-referenced with other public health indicators that is very useful. And moving back, when current funding resources are limited for adding more sites to our region and right across the province, essentially they've run out of money and they're waiting for the tabling of the next prevention budget. So they're hopeful, they're very enthusiastic that they will be refunded and that they'll be able to expand this into other areas. We had a discussion the other day with the regional team that they're waiting to add more diseases of public health significance into this. Influenza A, E. coli, salmonella, things like that, which to us would be really interesting and really important, because when these diseases get into our vulnerable populations in long-term care, they can wreak havoc on that population and lead to death. So knowing that these things are circulating at increasing rates in the community could be very helpful for us. And that's all I've got. I'm happy to take any questions. Thank you.
Great, thank you so much, John. Anybody have questions? I see Jeff Earl and then Bill Dobson.
Yeah, I have a question. That this technology looks very interesting for monitoring coronavirus and any other types of virus. Now, and it certainly seems more modern and maybe a little better at predicting faster results. Should be turn around a little faster. So, which on the outside seems to make it a fairly good tool, but then I rated another part that it, to get it implemented and accurate, it needs more funding. So the question I would have was, is this more relevant than some of the testing methods we're currently using, which instead of asking for more funding, is if we take funding away from something that's not turning out to be so effective, and this will do a better job, perhaps for less money, but certainly it'll put the warning signs up a lot faster, which is pretty useful information for a pandemic.
Thank you, Jeff.
I agree with you. The early warning signs are really important, and they're really fundamental to that type of surveillance. It's syndromic surveillance, sentinel surveillance, it's early warning, but it's not specific. So when you're talking about other types of testing that are very specific in identifying a disease, whether it's COVID or it's not COVID, this is not a replacement for that. It's an addition to that, and it's keeping in mind that we use it for early warning, which is its original intent. So to tell us that something's coming before it actually hits.
No, but I guess the question was, and it was a little more broad spectrum than one thing. It was, is there something that we're using now that, we have found that, with the uptick in testings and types of testings and the rest of it, that, we were using technology that, 2 years ago might have been okay, but it might have been technology from the 60s for all I know. Are we doing some old things and we just keep doing them because of habit, and that, instead of trying to ask for new funding, can we throw some of the old stuff out because it's just dated and replace it with newer technology like this?
John?
Oh, sorry, I would have to, this is part of my opinion. Paula could probably add a lot more to this. I mean, with COVID, the types of testing we were doing were absolutely relevant to the disease we were trying to track and to identifying people as early as possible. So the PCR tests, absolutely, we need to continue doing that. So yeah, to me, this and the tests we're using are on two different tracks. They're parallel to each other, but totally different uses.
It's Jeff, it's a really, really good question. And I think we're going to need to continue to have some of the testing of people, the PCR testing, because that's how we detect if there's a new variant, for example. And the question is, how much of it do we need to do? And are we doing the right amount now of the very high stress people, the people who have chronic conditions that they would be more serious? It's really useful to know if they had COVID. Like, it may be that the amount we're doing right now is the right amount, and we shouldn't put more into it, and we should be looking at this other. It's a really good question. Really good question.
Yeah.
Well,
And
one of the reasons I ask it is that every time we add something without subtracting something, it goes on somebody somewhere's tax bill. And so if it gets added on and something doesn't get taken off, what you're doing is on the lower levels of taxes, you're increasing poverty, which has its whole other set of health implications.
all right, then, thank you for that. And the number of the questions I had understood originally, now I get what you're fully going for, was did we actually determine that any of the testing that we were doing was less valuable, that we reached the point of saying we may not continue it? But you're looking for a trade-off. If you're going to add one, then look for one that's less productive and not increase the overall cost. I think we've covered it. Go ahead, Doug.
Doug, that is the important point. Like, how much more PCR testing do we need to do to understand what variant is circulating and what are the characteristics of it? I think that is the point. And we've got low levels right now, which still gives us a sense about what's going on in the community. Like, we're tracking people. We're getting sort of 1,000 people or 1,500 people being tested each week. Like, so, and that may be enough. That may be enough to give us a sense about what's going on, combined with the other information. So I think it's a really good topic to think about. Yeah, it's good.
Yeah. Thank you then, Jeff. I'll go to Bill Dobson. Bill, go ahead.
Thanks, Mr. Chair. I guess through you, if I could ask a question to John. John, you mentioned that in the US that they're able to monitor specific buildings at universities and so on. And I think that's really amazing to be able to do that. But, well, it's not amazing. It makes sense that they should be able to. But I guess I'm just wondering, like, if we will be able to in the future, do you think, would we be able to do that in Canada? And the reason I'm asking is specifically because of, let's say, well, I guess Perth, the town of Perth must also have a treatment center. And I'm thinking, well, if so, then if we were able to monitor, say, a specific building like Lanark Lodge, which is one of the high risk areas, or any other long-term care homes and high risk areas, it would be really great to be able to do that. I just wondered, like, if you think that would ever come to Canada sooner than later, or what?
Well, I believe there is a project underway in Ottawa where they're actually looking at one of the hospitals monitoring various wastewater streams in the hospital, just to try, and I believe it's just an experimental project, it's not an ongoing one, to try and figure out if this application can be used at smaller scales to figure out where outbreaks are coming from in advance, potential outbreaks. That's all I know about that. At smaller community levels, getting to your point about wastewater systems, right now, I believe they have to use a non-lagoon system. So if your municipality is using a lagoon, I don't think they can use this technology for testing right yet. So right now, I believe it's Smiths Falls, Brockville, Kempville, and Carleton Place that are Canada's, excuse me, an LGO.
Thank you.
Right. Thank you, Bill. Anyone else? Did you have something, Peter? Go ahead, Peter McKenna.
John may have just answered it for me. I was going to suggest that I assume that the majority of residents of Lanark, Leeds, Grenville are having their waste treated in a public facility, and a smaller percentage are using, home septic systems and not appropriate. But it's not every waste facility that can do it. So I think you just answered my question. Thank you. The second one is just my concern with dropping testing, as we talked earlier, to go in another direction is I'm quite, and my family are very astute and well-resourced to go out and get the testing. So the PCR tests and others, those of us who have get more, and those who don't have, I'm assuming have many barriers to getting tests. And so we may be, by relying just on the number of tests as opposed to who is getting it, the worried well are doing very well, and I'm in that group. But the group that we really are worrying about may not be getting the testing. So it's not how we're testing, but it's who's getting the testing and how do we make sure we're testing the right people and the right population. So just an observation. Thank you.
Thank you, Peter. Anyone else? I have one if everyone on the panel is ready. John, you talked about, in terms of the wastewater, the shedding of virus. Just a question that struck me. Does the amount of shedding of a virus indicate anything about severity? Because we hear of people getting severe cases of, well, even Omicron, and others, for many others, it's milder. Does the testing pick up on any of that?
It picks up on quantity, but not, you're looking at things from a population level, not an individual level. Biologically, yeah, somebody early on can be shedding a lot more virus than later, or vice versa, and it's really dependent on the individual. But overall, we have patterns in viral shedding that we can look at, and wastewater surveillance is a good way of doing that. So yeah, I'm kind of roundabout answering your question. It's not that specific.
Okay, thank you so much. Is there anybody before I move to the next subject then? Well, just before we do, thanks Hannon and John. It's always interesting to hear data, to line it up with what we have been hearing by way of news, and appreciate very much. So thank you on behalf of the committee.
Thank you for your time.
So that takes us to our new business, item 7, and the first on the agenda is the land control program. I have a motion for that. I'll read it and then we can ask Dr. Struthers if she wants to comment. I see that there's an indication on our agenda. So it is moved by Cheryl Smith, seconded by Doug Struthers. The motion reads that the Board of Health approve the 2022 land control budget in the amount of $693,175, and that 19 municipalities will be notified effective October 1st, 2022, that the health unit will no longer be able to provide the Ontario Building Code Part 8 services on their behalf, and that the health unit land control staff will support the transition of the program to municipalities. So I'll open that to discussion. And Paula, did you want to have any comments on it before the rest of our committee members?
Yeah, so I asked Tony to do it as chair of the finance committee because the finance committee has been walking lock and step with us. And they, yes. They would then report to the board.
Yes. So Tony, I'll ask what comments you have before I open it up to the rest of the board.
Maybe I'll just walk through the brief, Mr. Chair, if that's okay.
Yes.
Okay, so as of January 1st, 2022, the health unit has a formal arrangement with 19 of 22 municipalities to provide land control services. And this program is entirely self-funded through revenue generation. The 2021 service requests were quite high, and you can see on figure 1 of the package, the types of requests that were given to the health unit were zoning, subdivision, site assessments, sewage, and severance. And it's predicted that this kind of service request growth will continue in 2022. The increase in service demand means that the health unit can no longer maintain the land control program alongside the Ontario Public Health Standards programs and services for which they are mandated to do. So there's been work and conversations and discussions that have been ongoing with municipalities to support municipalities to identify an effective way to ensure that they meet the Part 8 requirements of the Ontario Building Code. The health unit then, so we finally have a date. The health unit will continue to accept service requests up to and including September 30th, 2022, and it will take about 12 months to complete these requests. The health unit will also provide support to the municipalities during the transition in 2022 and through September 2023. You can see the budget. So we're approving the 2022 budget. In 2021, the land control program is projected to have a significant surplus of $188,042 due to the continued high level of service requests, which actually started in 2020. There are currently 3 public health inspectors plus the chief building official working on the program, along with 2 admin assistants. They will all be needed through to December 31st, 2022 to both complete service requests and provide support to the municipalities. So if we looked at the financial statements for the land control program, the service requests revenue brought in $744,977 over a projected $631,124. And expenses actually were less than anticipated at $556,935, which brought us to a net budget and a surplus of $188,000. If we looked at 2022, then the projected budget is $693,175, because we'll be providing service to September 30th of 2022. There are some additional staff costs. There will be staff that will continue to support the municipalities through 22 and 2023. And there will be some additional transition costs that the budget will absorb, insurance, data management, legal costs, etc. So the total budget for 2022 is $693,175.
Thank you so much for that update information. So I'll open the floor. Do you have any questions by members of the committee? Go ahead, Doug Struthers, and then Jeff Rowe.
Thank you very much, Mr. Chair. And not so much questions, but to help perhaps continue to give a really good perspective of where we have been over the last year or so, where we are now, and moving forward. It's pretty clear where we've been in the last year or so, as Tony outlined. How we got to where we are today, some really good, I'll say, briefings with municipal staff, the CAO, and or the chief building official levels, for those that have chief building officials who are qualified to be Part 8 septic inspectors. And then briefings with the mayors of Lanark, Leeds, and Grenville to make sure everybody's on the same page and a roadmap forward. And during those consultations and or briefings, it certainly initiated conversations, I do believe, with a number of municipalities to see if they can partner, work together, because not every municipality may have a building officials who are qualified to have the training. Certainly, I know, and it's no news to a number of the mayors on the line here today. I think Doug, I'm not sure, Peter McKenna, I know you're not a mayor yet, but certainly Mayor for Wolford working with Smith Falls and Prescott over the last number of years with, it's always a shifting of great people in your municipality from an employee perspective. Our chief building official retired in the spring of, I'm sure I have the right year here, 2020. Not a great time for us in the municipality, but we work with others. Anyway, not to get too far sidetracked, there may be partnerships, that already have initiated development, or may over the course of we'll call it the transition period. And also in our particular case, and I think they have reached out, the Rideau Valley Conservation Authority, they do have people who are qualified that can, with a similar MOU that we already all have with the health unit, and the health unit has shared that, and so on and so forth. So while at first it may have seemed like, oh my gosh, what are we all going to do at the municipal level? There's some, I don't want to overstate it, there's some every municipality ought to I'll say land in good stead because of the advanced news shared with staff, shared with the mayors, and this a really, really good timeline of when it will take place and the support that the health unit staff will provide to municipalities a wee bit longer should that be needed. So, c'est tout là.
Thank you so much. Jeff, do you have something?
Yeah, the in 6 months from now, a bunch of us may or may not be grabbing a new pair of shoes and running around neighborhoods, and and we're probably all going to be holding our hands up and saying we support affordable housing, need affordable housing. I'd be surprised if no one doesn't have that as somewhere on their brochure. So my question is, and I'm involved with a subdivision in a small way that we're approving in Brockville, and it took 18 months to get the approvals, and the roads and sewers are taking probably 3 months to go in. So what that tells me is that the approvals and the bureaucracy is harder than the building. And so I guess what 3 months versus 18 is 1/6 the amount of time. So I guess my question is we all talk about cooperation in this, but the timelines for getting approvals is something that I think should be part of our measuring process, because if it takes 6 times as long to get the approvals as to do the building, then you're not going to help affordable housing very quickly. And again, affordable housing is kind of a health issue, particularly if you have a lot of homeless people. So I guess what I'm saying is whatever we do, we not only have to keep an eye on the revenues, but we need to keep an eye on the speed. There's, I think, in all communities, there is a need for affordable housing, and I don't, for any way, shape, or form, want a service that this health unit providing to slow it up. And I'm not saying it is slowing it up. Don't anybody get sensitive, but I'm just saying every part of this process of getting things approved has to speed up if we're going to solve this homeless problem, because a person camping outside may not be quite as able to endure a holdup as someone that's sitting in their nice warm living room like we all are now.
Thank you, Jeff. I see Doug Struthers wants back in. Go ahead, Doug.
Yeah, just very briefly, and I naively or not, I see 2 aspects of, and I'll say on the septic side, inspection. Replacement, I would imagine that the timelines are pretty tight on that. If you're having a septic system that needs to be replaced, it would be done somewhat expeditiously with tight timelines. You can't take a septic system out and wait 3 months for the new one to be in and inspected and functioning. So, and I think those timelines are, reasonably historic and would be the same moving forward. In terms of a new build, single build, or even potentially I'll say, a small subdivision of whatever size that people are going to be on well and septic, that would be all part of the planning process. And so the final inspection, if you will, of the septic system is usually more the front end of development that takes time. The septic system at the end is everybody knows, the builder, the homeowner, that you're going to need a septic system. So from my perspective, that ought not be a challenge moving forward, whether you're changing, partnering with other municipalities for those inspections, or in our case, looking to the conservation authorities. Notwithstanding that, Jeff makes a very good point, but I don't think septic inspection is going to be an obstacle for expediting new builds. Thank you.
Thank you. Jeff, and then Peter, you wanted to respond to that, Jeff, and then Peter.
Okay, I'm not suggesting that we're slow at doing them. I'm just suggesting that part of the measuring process should be how fast we do them. It's how much money. And there, I haven't heard of the septic being a large holdup, but the building permits and the zoning, that type of stuff is atrociously long. Matter of fact, I've been associated with a tiny homes, 2 built in Brockville, and we've given up dealing with the municipalities. Those are we're going to ship those off to an Indian reservation. They seem to be able to make stuff happen faster than municipal structure. So there's 2 houses for could have been placed in Leeds and Grenville. They're already complete, and one of them's got tires on it ready to move, and they're moving, but not to Leeds and Grenville or Lanark.
Yeah.
All right, thank you, Peter. I'll go to Peter McKenna.
I just want to speak in support of the recommendation, and I fully endorse it. My one question is, and I don't have the right term, but is there any legacy risk that we would retain? For example, if the health unit approved something a couple of years ago, what's our risk, and how do we either mitigate that or keep our eye on that and something like that? It's just, I'm not sure that's the right term.
Thank you. And Paula, go ahead.
So we've been speaking to our lawyer who's been with the program for 35 years. He's very concerned about that as well. The good thing is that we have a very healthy reserve, and that he has told us that we should be keeping a significant part of that just for that situation. We're also keeping, while we're transferring the records to the municipalities, we're actually keeping a copy ourselves, so that if we were ever to be called, then we would have all of our notes and everything that went along with that. So yes, that is absolutely something that that we're making sure we're sound on. Thanks, Peter.
Thank you for the question. Is there anybody else? I'm going to move to the question then, it's been a little bit of time since I read it. Unless somebody wants me to reread it, I will, but I think we've looked at it fairly comprehensively. So I'm going to call a question. All in favor of the motion? And the motion's carried. Thank you all. That takes us to item 7.2. The subject is one-time funding proposal. Again, I'll read the motion that goes with it. It's moved by Tony Circle, seconded by Jeff Earl, that the following 8 proposals be included in the 2022 submission of the annual service plan to the Ministry of Health. They include 1, COVID-19 general, 2, COVID-19 vaccine program, 3, extraordinary pandemic recovery, 4, public health inspector practicum, 5, vaccine refrigerator, 6, needle exchange program, 7, VDI infrastructure, and 8, nicotine replacement therapy. Dr. Stewart, can I turn to you and let you provide any comment you want before I open it up?
Yes. So it was very exciting when the province said we could apply for up to 8 one-time proposals. One-time proposals are 100% funded by the province, and the categories. So 1 and 2 were very specific categories. We have been able to apply for one-time funding for those projects for 2020 and 21. And this is about as much as we actually, the additional costs we had in 2021. We've done a lot of thinking about exactly how much we're going to need going forward, with some uncertainty, because we're not exactly sure what the vaccine program will be, but the province has given us guidelines that they've asked us to follow. So I think that's okay. And then the province recognized that we have had to put some programs on hold because we had to bring people from those programs into the COVID response. And so they are allowing us to apply for additional sort of OPHS funding for catch up. So the two things we've identified are we have not been able to provide the grade 7 vaccine program for HPV, meningococcal, and hepatitis B for 2 years now. We actually snuck in there in the fall of 2020 when things were pretty quiet. So we're so with additional staffing, then we can actually pick up that program. We actually have kids in grade 7, 8, and 9 who need catch up now. And if we don't do it this year, then we're going to lose potentially those kids. So, and then the other program that we're really behind is inspecting food premises, the personal service settings, all the regular places that there's a very strict schedule about when you're supposed to be inspecting them. So we're putting in additional funding so we can hire a couple more public health inspectors to get caught up on that work as well. And then the province said they're really keen on supporting public health inspectors after they graduate. They have to do a 4-month term at a public health placement for them to be able to then write their exams in the fall. And we've done really well with this program and often have hired people at the end of it. So we'll continue to do that. They also said if you need a new vaccine refrigerator, that every single year they ask us for that, because obviously that's a critical part of the provincial program. So we'll put in for one for that one. And then the needle exchange program, I'm really pleased that they specifically said that we could apply for funding within that program, because as you know, and we're going to talk about more at the April board meeting, we have a really serious opioid problem right across the province. And a big thing that we can contribute to reducing the risk that people develop hepatitis B or HIV is to be able to provide clean needles or other paraphernalia. So to be able to provide more of those resources, and that people come and drop off their needles with us. So they bring the pile of used needles and get the new ones. That means that those needles aren't out in the park, and we have to pay to dispose of them. So really pleased about that one. And then we're allowed to submit a project for capital infrastructure, and the capital that we really need relates to our computer system. It needs to be replaced over the next couple of years, so we're putting in quite a significant amount, you can see, for that. That is one that if the province doesn't fund it, we're going to have to come back and look at using the reserve for it, because we can't take that out of operating. So just for you to know that. And then we could apply for additional public health sort of program, and we chose the nicotine replacement therapy program because cigarette smoking is a major driver of so many of our chronic diseases. And so, as Peter said, some people who have insurance programs or have money, they can buy nicotine replacement therapy. There are lots of people that can't afford it. And we have a really good program where people from hospitals are referred to us, primary care is referred to us, so that we can give them the nicotine replacement therapy that they then can use to help stop smoking. So we've put in an amount for that. So I would love it if we got all aid. We put them in with a good rationale. The province says the board must support all of these, or else that's it. So that's why we bring it to you. We'll submit it by March the 1st, by Tuesday, and we're hoping to hear by early May, so that the province wants to give us our budget and let us know about these one-time projects before the election comes into play. So hopefully you'll agree with us that those are really important things to ask for 100% funding for.
Great, thank you very much for the report, Dr. Stewart. I'll open the floor then to questions or comments.
Nope.
I'm seeing a thumbs up, so I'm going to call the question. All in favor of the motion? And the motion is carried. Thank you all. That moves us to 7.3, and I'm going to have to excuse myself from this point of view. Normally I operate with 2 computers, so I'm not printing out material. My second computer has failed, so I don't have my access to my notes. So I'm just going to introduce the subject simply as there was a need to appoint the chair and vice chair of the government's committee, and the government's committee met, and we have the following nomination by way of a motion, and I have it moved by Doug Struthers, seconded by by Bill Dobson, that Cheryl Smith be appointed chair and Peter McKenna be appointed vice chair of the Governance and Quality Assurance Committee. Is there any discussion? I'm going to call a question. All in favor of the motion? Thank you all, and the motion's carried. And I want to thank very much both Cheryl and Peter for agreeing to let your name stand. And at the same time, Ann Warren, the former chair, is not able to be with us at this meeting due to an illness. And so I want to publicly thank her for her role as chair in the past year. She did a terrific job and worked hard at it. So with that, thank you all. Then on to 7.4, which is the MOH update, and back to you, Dr. Stewart.
Okay, so the first part, Hanan basically shared with you. I usually give you a status update. The number of new infections, so the people who can get PCR testing, has started to decrease since the start of February. January was still pretty high, but it's going down. It's not the whole population, but I think it gives us some reflection about what's happening. We still do have COVID in the community, though, so that I keep telling people that don't think that it's gone off someplace. It's still here. The good thing, though, as Hanan showed you, is the number of new hospitalizations has really, really dropped, particularly in this last week, which is, remember, that was one of the major motivators in terms of having people ramp up the provincial precautions. But it's just dramatic how it's, and we're following that trend, which is important because the healthcare system needs to be available to other people who need to use it. So that's really good. As Hanan showed you, our outbreaks have gone right down. You know, it's been, for me, remembering what it was like to have outbreaks in March 2020 compared to now when we've got vaccine, it's like night and day. We have had a few deaths, but the vast majority with 3 or 4 doses of vaccine are really coping well. Mild symptoms, some of them, they test positive, but they don't even have symptoms. So really, really pleased about that. And the long-term care retirement homes, the group homes, they know what precautions are needed. We help them out, but it's such a different situation here than it was 2 years ago. So what's really changed with us in our messaging now, because things are going down a little bit, and the province is lifting precautions, and we'll see what happens on Tuesday, March 1st. Our messaging is now living well alongside COVID-19. It's going to be here just like the coronavirus was here before, and it's a matter of taking what we know about the virus, each of us, our families and our friends, knowing that we can put precautions in place and thinking about what it is we want to do and how can we put in the precautions that are appropriate for that particular situation. And really, really encouraging people to focus on health, eating well, being physically active, getting enough sleep, that's a big one for me, connecting with and supporting others, and getting out and really participating in activities. And thinking about when you want to use the masking. For sure, everyone should get vaccinated, get the 3rd dose, makes a big difference. Staying home when sick, for sure, testing if it's available, washing hands, hand sanitizer, all those things, avoiding crowded spaces, physically distancing. But there's so many things we can be doing within that, and really encouraging people to live well now. For vaccine, we're at 90.9% of our 5+ have had at least a 2nd dose of vaccine. Really pleased about that. Our 5 to 11-year-olds, we're now up to 64% with the 1st dose and 41 with the 2nd. The nurses were saying that it's the young kids, it's that 5 to 11-year-olds that are mostly at the clinics now, and they know what they're doing. They've been there before. They're going back to the same place. They know it's not a big deal, and the nurses love having them there. There's energy, enthusiasm, and so on. The 3rd dose is really coming along well. We're almost 70%, 69% of the 18+ have had their 3rd dose, and that makes such a difference. The 3rd dose gives protection, 61% protection against symptoms, 95% protection against hospitalization. So incredibly important. Our vaccine clinics aren't very full right now, so lots of walk-ins coming in. You can book online. We're really, do you remember in the summer when the fixed sites went down, we moved to go out to people? That's what we're doing now. So we are booking into small places, whether it's a workplace or a youth center or something, and really exciting. Remember how I said we the GoVax bus from the Toronto area came to us. And Becky Kavanaugh, who's our lead, oh, she was so excited about that. I could just see the wheels turning. So we've actually rented an RV, a small RV, during March break and the week after, so that we can go to where people are. So we're talking to our partners and go to a neighborhood because it's self-contained. So it's actually, it's a really exciting part of the vaccine program because now we're going out to the people. And if there are particular places that the board members think it would be good to go to, please let me know. Because kids will be available in the March break, we're hoping, and it's heaven. And I think I'm trying to think what it's the van is going to be called the Vaxi Taxi, which is really cute. And we're going to do, it's the Vaxi Palooza that's going to be going out. So if you can think of places, we are mobile. We have a team of 3 people, 2 nurses and an admin assistant, who are going to be driving it around and going to places. And we'll have the places where we're going to go up on the website, and it'll be drop-in. Who said vaccines are boring, eh? So the reopening Ontario, as Hanan said, the hospitalizations and ICUs are down, which is why the province is starting to lift precautions. What I've been saying to people is what this means is we're not in an emergency situation anymore. The province had to intervene when we really weren't sure what we were doing, and we didn't have patterns, we didn't have ways of doing things that were protecting others. We're in a totally different place now than where we were 2 years ago. We now have the information that we can use to make good decisions. Workplaces and businesses can decide what they're going to do. So it's a neat place to be in. I think that when you think as a collective, all of us have learned so much and have developed new patterns, new ways of being flexible and adapting, even having Zoom calls, like to see everyone like this where you didn't have to drive, like, you know, and so how much of that do we need to keep going, and how much of the past will we need to be doing? Which leads me into, that's the work that we're doing right now in the health unit. We had started in the summer, we had a great plan for how we were going to gradually keep the COVID response and add the OPHS programs and services. And then Delta hit, and then Omicron hit. But now we're at a place, I think, where we're going to bring that back. And the management team spent the whole of Tuesday morning really talking about it. And bringing back the planning. We have really good planning tools. We have a really good health equity assessment tool, Peter, that we've been using all along, and now we're going to bring that back. So as we're talking about what programs, breastfeeding, prenatal, you name it, then using that health equity assessment tool to make sure that we're in fact reaching the people that we need to be. We also have, there's another tool called Plan, Do, Check, and Act. So you do planning when you're looking at doing things a little bit differently. You plan it, you do it, you check it, you evaluate it, and then you act on it. So this is going to be between now and May the 1st is really going to be a really concerted effort to identify what we should be doing going forward. You remember that as part of our plan, we hired a consultant firm to help us with our learnings from COVID-19 in 2021. And the consultant team was very, very good. I shared the full report with the governance committee. We're going to be, management team is actively looking at what are the things that we can build on, because they really identified some really good things we'd figured out and keeping those, and then some opportunities for things that we can change. And so that report is coming into the planning as well. The other thing we're doing right now is we had talked about, we have 2 empty director positions. We've hired a firm who will be working with us to actually review the organization, the program organizational structure. Really pleased with them. They started, I think we approved it on Thursday with the governance committee, and we had a meeting on Tuesday, and we are bang, bang, bang. Interviews are being set up. We'll do focus group with the staff. They are very experienced and really looking forward to their input into what we do going forward. The expectation is it'll be finished by the end of March, and the way we're going, I really think we'll make it. The last thing I wanted to mention is March is Mental Health Month. And the Royal Ottawa Mental Health Centre has come up with a new concept called mental hygiene. So just like you look after your teeth, like and you shower and you bathe yourself and so on, the idea is what can you do to be cleaning your brain in a way? And they're encouraging people. I signed up for it. There's a mental health challenge that you sign up at the beginning of March and then do lots of things. And they have lots of ideas to really help get your brain so it's functioning well with resilience. And I think at this point in time, when we're tired and we're trying to make a shift in terms of how we approach COVID, this is, I think, really, really good time for it. And they talked about needing at least 10 minutes a day, all at once or a shorter interval, so it sounds like physical activity, on mental hygiene practices. They're calling it things like focused deep breathing. That centers you and stops the brain from spinning. Mindfulness, really being aware of where you're at right now, blocking out the extra things that are sort of going on around you. Gratitude exercises, things that were helpful for journaling, and lots of other suggestions that are up on the website. So we're really promoting it on our website and our social media. I mentioned it in my media this week. And the website has the page where you can go to sign up for it. So so I leave you with that. This is a good time for the health unit. I think we're getting energized and have a sense that we are learning from what we've done over the last 2 years, and we'll be really responsive to the community as we go into this next phase.
Thank you so much, Dr. Stewart, for a very comprehensive report. There anybody that wants to provide any comments or questions? I'm seeing none, so it appears to be very satisfying. I found it exciting. I pick up very quickly too the positivity that exists in the health unit and the employees. And I think that is a sign of the things are getting better. The pressures are, or at least being relieved a little bit. I certainly won't say they're off. But very positive sense in the air, one that I share. So thank you very much.
Welcome.
All right, then we're on to item 8, which just confirms the date, location of the next meeting, which is April the 21st, 2022. So no meeting in March. And it still will be virtual unless there's some indication between now and then. So with that, we're on to the last motion, which is for adjournment. I have it moved by Jeff Earl, seconded by Bill Dobson, that the meeting now adjourn at 5:30 p.m. All in favor? And we're adjourned, and thanks so much, everyone. Have a good rest of the evening.
Thanks, and we'll see some of you or many of you in the morning.
Exactly.
Bye.
That's, yeah. You can phone me, don't nudge me.